Hi, everyone. It's really nice to be with you and to be able to talk to you about what is a really difficult topic during a really difficult time. But I'm hoping that this sheds a little bit of light on something that Canada is grappling with and continues to grapple with. So I want to start by talking a little bit about the kinds of COVID-19 data that we routinely have seen during the pandemic. So if you look at the top left-hand corner, that's a sort of graphic of the total number of cases. This is as of July 19th. It tells you how many people have recovered. It tells you how many deaths we've had and how many have been in institutions. On the bottom left-hand corner is the cumulative cases. And in that graph, essentially what you're seeing for any given day is the number of cases for that day plus any cases that have come before it. So it's cumulative in that sense. And you see that the numbers rise over time because you're picking up prior cases as well. And on the right-hand side is the number of cases per day. So this fluctuates a bit more because any given day is just the number of cases on that day. And we've routinely been seeing data like this that kind of presents an overall perspective on what's happening with COVID. And if you listen to our public health officials, our politicians, this data comes along with a lot of messages about solidarity during this time of COVID. This is why we're seeing sort of these figures presented as an overall picture of what's happening in Canada or what's happening in Toronto, et cetera, et cetera. And yet there's this kind of uncomfortable truth, which is that as the pandemic unfolded, we kept seeing stories in the media highlighting particularly personal support workers who seem to be dying. And this is a slide that shows a picture of 3 of the earliest cases that were reported in the news. And so people started asking whether it's actually true that COVID was being experienced uniformly by Canadians, by Torontonians, by people in localities, or whether there were actually some real differences in who was at risk. But early on, we actually didn't have a lot of data to be able to get at that question. It was just a question of, these news reports are occurring. Are they systematic or not? Is this indicative of a systematic finding? And then in late May, after a lot of pressure, came data on this topic. And this is one of the earliest presentations of that data. This is a map of Toronto, and it's been shaded in terms of how many COVID cases have been experienced in different Toronto neighborhoods. And the darker the shading in the neighborhood, the more cases of COVID. And you can see from this picture that you have higher levels of COVID in the northwestern region of Toronto, much lower in sort of central downtown areas. And if you actually take a look at the numbers, the lowest case counts in Toronto were in neighborhoods like the Danforth, Yonge and Eglinton, the Beaches. The highest case counts, Jane and Finch, Rexdale, Downsview. And take a look at that difference. I mean, that is a 40-fold difference in cases. And those aren't randomly distributed across types of neighborhoods, meaning not only are neighborhoods different in their COVID counts, but the types of neighborhoods that are having high and low COVID counts are very different. You see much lower cases of COVID in white, wealthy neighborhoods, much higher in Black working class neighborhoods. And that's kind of the piece that we are contending with that we didn't get presented to us early on in the pandemic by our public health officials and by our politicians. Moreover, this is really not just a story of income. So if you look at COVID cases by income group, you can see that actually the differential doesn't precisely mirror what we see for race. So there's something particular about Black working class neighborhoods as opposed to just working class neighborhoods that we think carries some indication of what risk factors for COVID are. Is this at all surprising for those of us who do this work, who are in the sort of mission to understand racial health inequalities and to do something about them? Unfortunately, this isn't surprising at all, and many people predicted this right from the start. Why? Well, I'm about to show you a lot of data that suggests that health inequalities are long-standing, and there's no reason to think, even though COVID is new, that this would be any different. This is a picture from the US where most of our knowledge about racial health inequities comes from, because that's where the data is most readily available. So this is life expectancy by race and gender. And one of the most striking things about this figure is not just that you see Black-white inequalities for men and for women, but that even as things have improved for everyone, inequalities have been maintained. So you see the same gap persist even as people's groups' life expectancy increases. So what do we know from this evidence? Well, one thing we know is that, as I said, racial health inequities occur for almost every disease and every disease mechanism of which we know, which is really staggering. This is not something that's isolated to a particular set of health outcomes. The second thing that we know for sure is that race has no genetic basis. So when you see racial health inequities, when you see racial differences in life expectancy, this is not, cannot be attributed to genetic factors. And I'll tell you a bit about that shortly. The third is that we've learned racial health inequities are really the result of differences in material and social conditions, and that those are due to systemic or institutional or structural forms of racism. In other words, the reason you see racial health differences is because racial groups have different opportunities and chances to live healthy lives, and that itself is a function of broad spread discrimination. So the first lesson, the fact that racial health inequities occur for almost every health outcome we can think of. This is, again, US data of racial differences in in infant mortality. And you can see, again, things have improved over time for all racial groups. Infant mortality has come down, but that gap persists. And that gap is the difference between a white life expectancy that is sort of more in line with what you see in other high income countries, and a Black infant mortality that is more in line with middle and sometimes even low income countries. It's a really staggering difference to have infant mortality, which is, you know, really not that common in high income countries, still be so high for a particular racial group. Adulthood, same thing. So throughout the life course, this is racial differences in hypertension. And you can see in the mid-blue bars that non-Hispanic Blacks in the US have much greater rates of hypertension than other racial groups. Premature death, same story. You see much higher rates regardless of the age group of premature death in Blacks compared to other racial groups. So really across the board, every health outcome you can think of, every stage of life from birth to death, we're seeing a similar pattern. Again, no genetic basis for this pattern. This is a slide of a study that was done in Illinois. And they wanted to understand what the birth weight distributions are for three groups in Illinois. One group is African-born Black women who gave birth in Illinois, meaning they were immigrants from Africa, came to Illinois and gave birth at some point after becoming residents of the US, but were not born in the US. US-born Blacks, that these are Black women who have a long history in the US, are likely descendants of slaves in the US, so multiple generations spent in the US. And then ditto for US-born whites, are likely multiple generations out in the US and gave birth in the US as well. And what they wanted to know is, what are the birth weight distributions of these three groups? And if you look at the graph, the two birth weight distributions that are most similar are the birth weight distributions of US-born whites and African-born Black women. So the least similar is US born Black women, and that's actually a riskier birth weight distribution. So it's shifted to a riskier point because lower birth weight tends to be more risky. So it's a really intriguing finding, because if we were to propose a genetic mechanism for birth weight, you might imagine that African-born Black women and US-born Black women would look more similar, but they don't. This is another study where they looked at diabetes in the Pima Indian group. And diabetes in indigenous groups is something that is really, really alarming, and people have been trying to figure this out. A lot of funding has gone to figuring out whether there is a genetic basis for diabetes in indigenous groups, and indeed there is not. This is a study where they said, okay, here's this Indian group, the Pimas, who live in two different countries because a border essentially bisected their society. So half of them live in Arizona, and then half in Mexico, or some proportion in Arizona, some proportion in Mexico. And if you look at diabetes rates of Pima Indians in Mexico, it's about 6.9% of the population, less than 1/5 the proportion of US Arizona Pima Indians, in which the diabetes rate is about 38%. Same genetic group, only differ because a border crossed their society, and it's impossible to make a genetic argument for diabetes. And this is a sort of schematic that's been done by the Human Genome Project, which mapped human DNA for a variety of reasons, and came up with a variety of results, one of which was about the racial basis or lack of basis in genes. And on the left is what they say is the misconception we all have about racial groups. And that's that we somehow maybe have some shared genetics because, after all, we're all human, but that we are sort of these distinct genetic groups. And on the right is what they say is really the actual facts of the matter, which is that we overlap almost entirely. And where we don't overlap, it's very difficult to attribute that lack of overlap to a particular genetic group. There's no distinct kind of genetic makeup that we can attribute to race. So the basic reality is that the kids you see in this picture going forward in life will have very different chances at good health. And the reason for that is not because they are genetically dissimilar, it's because they will lead different lives. They will have different opportunities for health. So this is the final thing that we've learned, that this is effectively about differences in material and social conditions that essentially lead to differences in opportunities and circumstances, and that is all wrapped up in a system of racism. So effectively, this is, you may have heard this term, social determinants of health. This is a story of differential access to the social determinants of health. Differential access by race to economic stability, good neighborhood conditions, health and healthcare, education, et cetera, et cetera. Let me give you some data that highlights this, again from the US. If you look at the left-hand graph, that is the gap in income, in median income for Blacks and whites. Again, same sort of story where you see improvements over time for both groups, but a consistency in that gap. And if you look on the right-hand side at wealth, it's even worse. So part of the reason it's worse is because white wealth has increased and Black wealth has essentially stagnated in dollars that are adjusted for inflation. So you see these really large gaps in the basic economic well-being of Blacks and whites. And that is a fundamental premise of why you see large health gaps, including large COVID gaps. This is a graph that depicts the fact that it is about income and economics, but it's not only about income and economics directly anyways. This is asthma rates of Black and white children across income groups. And you can see that even at high income groups, you're not seeing a complete convergence of asthma. You're seeing higher rates of asthma in Black children compared to white children, even at higher income ranges. And again, this is not a genetic story. We aren't genetically different groups, so we cannot use genes to explain this. This is a graph that shows various studies that have looked at racial differences in hypertension. So this is a very big literature. So people have done some systematic reviews around this. And again, you see differences in hypertension, not just by race, but in this case, by racial discrimination. So what people think is happening is a combination of life conditions that are detrimental because of lack of economic opportunity, plus direct biological, physiological implications of experiencing particularly persistent discrimination. So the story is that not only is racism harmful because it reduces opportunity, but it's also harmful because it actually biologically embeds in several ways, including through hypertension. This is a study where they looked at something called allostatic load, which is a measure of physiological stress. It's made up of blood pressure, but also cortisol, a stress hormone, and some other factors. And essentially what you see here is a graph that shows allostatic load levels across age on the x-axis. And they did it for 4 groups, for whites, Blacks, and for each racial group, for people who are above a poverty income threshold and those who are below, meaning higher and lower income Black and white groups. And what's really fascinating is that the top 2 lines are the lines that have the greatest allostatic load, the greatest physiological stress levels. And both those lines belong to Black groups. So in other words, regardless of income level, Blacks have higher allostatic load than whites. So you could be a wealthier Black person compared to a less wealthy white person, your likelihood of allostatic load is greater. This is a study where they've looked at something called telomere length. This is part of the genome, part of the DNA. And it's what we've learned over time is that stress actually decreases telomere length, and telomere length predicts essentially your physiological age. It's like a way of measuring stress as well. And again, what people are finding is that telomere length is related to race, and it's not genetic. It's because the experience of being in a particular racial group carries with it a likelihood of whether or not you experience stress. So on the left-hand side, you see a clear pattern where Blacks have the lowest, smallest telomere length, particularly over age. It doesn't sort of, again, the gap doesn't decrease. And white in women, you see a slightly different pattern in terms of the crossover, but at the end of the day, what you're seeing is much smaller telomere lengths in Black and Hispanic women. This is a kind of schematic that gives you a sense of what exactly is going on in physiological terms. This is by Bruce McEwen and his colleagues who are neuroendocrinologists. And essentially what you see there is the brain, and you see that it perceives stress, and above the brain, they've highlighted some sources of stress: environmental stressors, work, home, etc., major life events, having the experience of trauma and abuse. And the idea is that the brain experiences these stressors and particularly experiences chronic stress. So what they find interestingly is that these kinds of major life events that happen once in a while, the death of someone in your family and so on, are stressful, but they're actually not as harmful to our health as the everyday chronic stress that may be sort of smaller in its nature, but it happens all day, every day. And that accumulation is really what's harmful for the body and the mind. So the brain effectively perceives this stress and then reacts to it. It reacts physiologically, as I mentioned, with sort of stress hormones, blood pressure, et cetera, being activated. It responds behaviorally. This is where things like your diet, your exercise, and so on come in. And the idea there is that even though in public health, we often think of behaviors as something that we can just educate our way through, that people have volition. If we just tell them it's good for them, that they'll do it, when in fact it's very related to the kinds of coping strategies you have to activate when you're under stress. In the case of allostatic load, again, the idea is that it's not that we can't handle stress. Our bodies are actually designed to handle stress and then return to some sense of normal. But what happens with load is that your body actually never has a chance to recuperate. So because the stress is chronic, even though it's low grade, the continuous activation is what's sort of harmful in physiological terms. So back to COVID. So COVID is a new mechanism. It's not about stress per se. It's transmitted because of droplets in the air and so on, and exposure that way to people who are close by. And so even though the mode of transmission has nothing to do with anything that I've described to you, a lot of people who do this work could have told you that this would happen, even though they knew nothing about the disease, nothing about how it's transmitted. And the reason is that racism and opportunity and stress are all kind of root causes, no matter what kind of downstream mechanism we're talking about. And here's a little conceptual framework to describe that. So imagine if on the right-hand side, that health outcome is COVID, or imagine it's cardiovascular disease. You can imagine that the kinds of ways you get COVID and cardiovascular disease are very different. And yet what this conceptual framework is essentially telling us, and what the literature is essentially telling us, is that it doesn't actually matter how you get the disease ultimately. Those mechanisms themselves, diet, exercise, being near someone and being exposed to droplets with COVID, are all patterned by people's material conditions, by the lives that they lead. And those things are themselves patterned by racism. So I'm going to give you some more examples of that. And actually, let me say one more thing, which is that I mentioned that the racial pattern in Toronto is not explained entirely by income. The other way to think about that is when you see income differentials in a health outcome, be it COVID or anything else, one question is, who are the people behind those income categories? And one way to think about this is that racial minorities, particularly in Canada, Black and Indigenous groups, are disproportionately represented in the lower income categories. So a graph like this is not telling us anything explicitly about race, but underlying this data is a story about race. So the Canadian story on this and the Canadian story on COVID is something that we've been working on. As I mentioned, I'll sort of give you some idea of what I mean. This is a study we did a while back where we tried to look at what racial disparities, racial inequities in health look like in Canada. And the bottom line is it's a really hard story to tell, because unlike the US, we don't have the same kind of data. So we really lack a lot of data to tell good stories. This was a study that was done from the Canadian Community Health Survey, which at the time was the best source of data we had for information on health, as well as information on race and other variables that run with those two things. So things like income, education, immigrant status, and so on. So in this graph that was covered by the Globe and Mail, you can see that it's a little bit of a mixed story. So compared to the US, you see some outcomes like hypertension where Blacks have higher rates, but in other outcomes, it's less likely to be the case. So for example, if you look at Aboriginals, for example, they often have the highest levels of disease. For other conditions and so on and so forth. For heart disease, you see a mixed result. So there's really some variability around the effect of race on health in Canada, and we've been trying to figure out why that is. Is it because it's a different society? Is it because immigrants who are newer, who we know tend to be healthier, are actually, so you've got opposing forces of race and immigration in this data, and so on. lately, what we've had access to is Statistics Canada data that has linked the census, the long form of the census, to our death records, to mortality records. And from that data, we've been able to link people's race to their death records and to look across immigrant generations so that we can tease apart that effective race and immigration. And so in this graph, we've looked at the relative risk of dying for different racial groups compared to whites in different immigrant generations. And so I'm just going to turn your attention to the general messages. So if you look at the bottom left-hand corner, that's the relative risk of dying for various racial groups compared to whites who are in first generation. And what you see is that actually whites, the referent group, have a higher relative risk than do each racial minority group in first generation. What ends up happening is that over time, that pattern changes a lot. So if you follow, for example, the purple circles across generations from the bottom left-hand part of the graph to the top right-hand part, you can see that the relative risk of mortality really increases significantly, and the ordering across racial groups really changes. So by the time you get to third or more generation, Blacks are more likely than whites to experience mortality during the course of the study that we examined. So it's not clear yet exactly what's going on, but you are seeing some convergence with the US story after you account for immigration. We've taken a look at, again, what are the sort of Canadian issues that are at play? What are the economic stories, and what are the sort of discrimination stories? Do they mirror what we're seeing in the US? This is a study where we looked at experiences of discrimination in different groups compared to whites. And these are, again, everyday chronic forms of discrimination. This is a scale that's been validated to sort of understand what is a kind of sort of chronicity of experiences that people have. So whether you're treated with less courtesy or respect, poorer service, treated as not smart, and feared by others. And fairly consistently, you can see Blacks and also Aboriginals are experiencing higher levels of discrimination. In particular, Blacks are experiencing almost 4 times the level of feeling like they are feared by others. 3 times less likely to receive poorer service, and so on. So really some striking findings from this study. And we're not the only ones. So Toronto economist Philip Oreopoulos did this really interesting study where he looked at the extent to which there is labor market discrimination in Toronto, at least. And he took off from a study done in the US where they looked at differences in the extent to which people would get called back for an interview if you had a typically Black name versus a typically white name. And that's not data we have in Canada that we can look at, but we did have access to understanding what are typically Asian names and typically white names, and so on. And what he found is not just that there is labor market discrimination for people with Asian names, but that it cannot be totally accounted for by Asians having foreign education or foreign experience, and so on. So when he looked at all of those factors, even when Asians had equivalent Canadian education and experience, they were still almost 30% less likely to get called back for an interview when they applied for a job. StatsCan has shown, just like the US, differences in median income by white versus racialized groups. Again, we are less sophisticated in our data and how we present it, so we don't have the breakdown as thoroughly by racial group for Canada, but this is the white versus all racialized group. This is by race for Toronto, and you can see again that the lowest earners tend to be Black, some Asian groups, compared to white and Japanese, who are the highest earners in Toronto. So again, you know, the coronavirus story is new. It's a new disease, and we didn't know anything about it, and yet knowing how life has shaped up by race, we could have predicted this. So if you look specifically at the kinds of material conditions that could predict coronavirus, you see how they break down by race. So I've kind of presented a general picture of income and so on, but the big issue for coronavirus has really been the who's forced to go to work story and who stayed home when lockdown happened. So if you were an essential service worker, you had to go to work, and that increased your exposure a lot. And this is StatsCan data that shows who is doing essential service work, particularly in this case, personal support worker work. And you can see how much more likely Black and Filipino people are to be doing that work. And this is, again, why income doesn't tell the whole story. So the labor market sorting of people by race happens not only because of income, but a combination of race and income as well. And I think now we have to ask ourselves these questions. Why is this pattern emerging? Why are, for instance, Black and Filipino more likely to be essential service workers? Well, not long ago, there was some coverage of the Ford government in Ontario, which intends to end streaming for grade 9 students. And so the rationale for ending this practice was that Black students in particular were being funneled into applied tracks in high school compared to other race children who were being differentially funneled into academic tracks. And this is what I mean when I say structural racism. This streaming system was a policy. So there were people who enacted it, but it was codified as a policy and is used as a mechanism essentially to sort people. And this is, you don't have to believe me. This is what the study showed, and this is what the government intended on acting on, that this was actually a structural thing they had to change. They couldn't just educate people not to be racist and not to do this. They knew that they had to change the structure in which this was occurring. So you can imagine if Black children are disproportionately funneled into the applied stream, they are disproportionately funneled away from the kind of education that gives you the kinds of jobs that allowed a lot of us to stay home during the pandemic. This is a study where they looked at some demographic variables of people who entered University of Toronto and then graduated from University of Toronto. And for the sake of time, I won't go through this in detail, but you're welcome to pause and look at this. You can see that Blacks are much less likely than other racial groups to enter University of Toronto, along with Latin American and Aboriginals. And the graduation rate is abysmal. It's 50.5%. Half of Black students who enter U of T do not graduate. What we know along with this data is if you do studies where you ask people about their values, about how much they value education, it turns out Black people value education more than most racial groups, which is something we don't think about at all. We assume that there's some kind of cultural distinction in valuing education. That's not the case. This is a story about how people are treated at the university, what kinds of supports are in place, what kind of racism people face. This is not a story of will, and we have data to back that up. So recall this evidence I showed you about labor market discrimination and how people with Asian names are less likely to get callbacks than whites who apply for jobs. Well, again, this is the same kind of story. So not only are you funneled away from good jobs, but when you try to apply for them, you're less likely to get them. So you're more likely to experience material deprivation and to be in the kinds of jobs in the COVID era that expose you to risk. So in other words, the neighborhood story we started with that showed Northwestern neighborhoods in Toronto that were at higher risk for COVID is not a story of the neighborhood per se. That's just the level at which we have the data. That's a story of Black working class people who had to be exposed to the virus by virtue of the fact that they had jobs that required them to go to work. It required them to be on transit. It required them to live a life that was essentially risky for COVID, the same way it requires them to live a life that's risky for cardiovascular disease and life expectancy and mortality and you name it. And so that's kind of why we say we could have predicted this. Whether it's coronavirus or cardiovascular disease, the fundamental root causes, the racism, the effects on material conditions, and the effects on stress are there. And so no matter what health outcome you put in place downstream, you're going to see similar effects, if not now, tomorrow. And so imagine if we do something to kind of mitigate the effects of COVID on, say, Black people by implementing testing in neighborhoods and doing a bunch of things that help with coronavirus. We can do those things and we should, but unless you change the fundamental root causes that got us there in the first place, if they don't get COVID, they're going to get something else because we're fundamentally burdening them with a kind of risk for their health that we ourselves don't experience or shield ourselves from. And I'll leave it at that. Thank you.